Next up, we are going to jump back into our plenary talks. The first one that we have on our schedule is updates in obesity medicine. And I am going to give our speaker just one moment because we're just a little bit ahead of schedule. There we go. I have the pleasure of introducing Dr. Leo Kim. He is an internist specializing in obesity medicine with a clinical focus on sustainable nutrition, metabolic health, and pharmacotherapy for weight loss. And I've had the pleasure of working alongside Dr. Kim in the past when he was a hospitalist at Prov Everett. So we're excited to welcome him back today to teach us about his new specialty in obesity medicine. Thanks, Dr. Kim.
Thank you so much for your help. And thank you for the warm introduction, Dr. Goulet. Thank you so much for having me here with you guys. Learning quite a bit. And the big things I want to cover in this presentation is the latest updates that we have in the field of obesity medicine. And the biggest topics I want to go over is just all the news, all the new latest guidelines that have popped up over the past year, or say a couple of years. And one of the main ones is I want to cover are the latest updates within the new definitions of what's considered to be obesity, or the new definitions to diagnose or classify obesity, because the Endocrine Society has updated their guidelines and algorithm for that just a couple of months ago. And the other things I want to talk about is the rest of the talk will center around GLP-1 medications, just because over the past 5-10 years, they've kind of taken the pharmacotherapy realm of obesity medicine by storm. So more and more and more patients are being prescribed and are on these medications. So it's definitely good to kind of have the latest data on the efficacy and the safety of these medications, and importantly, the management of these medications. And one thing that I'll want to stress is the perioperative management, or what to do with these medications within the perioperative period before surgeries. Should you stop them? When do you need to stop them? How long do you need to stop them for? When is it safe to resume? And I want to go over the latest safety data that are associated. Side effects, risk profile with these medications, especially when it comes to the big ones. The big ones being pancreatitis and gastroparesis. A lot of eye complications have been floating around in the news and the media. And I think the latest one that I've been seeing is a discussion of whether these medications increase your depression or suicidal ideation risk. And at the end, I want to go over the latest or the new FDA approved indications for these medications, especially your Wegovy, which is semaglutide, and your Zepbound. Now, if you look at the current landscape of the disease of obesity, now we don't have any kind of up-to-date data from 2024, 2025, but based on the CDC map from 2023, it looks like, and this number, continuously blows my mind, but at this point, or based on the extrapolated data from CDC, is that a whopping 43% of adults in the US at this point have obesity. And the number that makes that's even crazier is that 75% of adults in the US at this point are considered to have either overweight or obesity. So if you walk out on the street, 3 out of 4 people that you'll see will have either at least overweight or obesity. And as you can see, in some states, the rates are higher than others. I've been going to, obesity-related conferences for about 10 years now, and without change, Colorado is still, for some reason, is the lowest. I don't know what is it about Colorado, or that, I don't know if it's a kind of selected population, but For some reason, Colorado is the last state in the union that's still green, but green meaning that they still have a 20 to 25% of population that is, considered to have obesity. And the numbers have been growing for the past several decades. Um, Now, it's not just the obesity. What we really, want to target are all of these complications that people may have from the disease of obesity. And these numbers get even crazier, at least for me. The latest estimates are that 1 in 3 adults, or 34, almost 38% of all Americans at this point, have prediabetes. So this is based on I guess they're not newer anymore, but somewhere newer definitions of prediabetes where you're of A1C being at least a 5.7. Um, and then 1 in 3 adults have, in the US, have beginning stages of fatty liver, or the new name for that is MASLD, or metabolic dysfunction associated steatotic liver disease, which replaced the older name, or NAFLD, non-alcoholic fatty liver disease. Um, and worldwide, the prevalence of fatty liver has just been exploding. And a lot of it, and the numbers are probably much higher because a lot of it goes undiagnosed, um, depending on the what population or what region you look at. But here's some good news. If you look at the latest population data, it looks like we may seeing the first signs of this obesity epidemic finally plateauing or even decreasing. So this chart is from the Epic Research Organization, which basically, combs data from all the health systems that use Epic EHR, and they looked at over 100 million patient data points, and what they're finding is that just over the past 2 or 3 years, we're actually seeing plateauing of rates of obesity and severe obesity, would be BMI of greater than 40. And if you squint your eyes, if you look very closely, you may even see that the rates may be declining. So I'll be very curious to see what these numbers look like just over the next couple of years, because I never thought we would see actual decline of rates of obesity within this decade. Now, what contributes to this change? What contributes to this plateau, or hopefully decrease in numbers? A lot of people suspect it's the increased use of the GLP-1 medications that have just revolutionized, the whole field over the past 10 years. But yes, it would be very interesting to follow the trend, and hopefully the trend continues to improve here in the US. Now, let's talk about the new definitions for how we classify obesity, how we diagnose obesity, how we classify it. And this is hot off the press from ACE, or the American Association of Clinical Endocrinologists. They just published this new algorithm back just a couple of months ago in September. And the main takeaway message there is to shift our classification and diagnosis guidelines from a more of a BMI-centric approach to a more of a complication-centric model, to where we still use BMI as a good screening tool, but it's not enough to have a BMI at a certain threshold to diagnose someone as having obesity. There's been a lot of emphasis that was put not just BMI, but also using your patient's waist circumference in as a screening tool, as well as a diagnostic and classification tool as well. Now we've all known this, BMI being an imperfect tool. Unfortunately, it's still used pretty widely for diagnosis. Unfortunately, many insurance companies are still using BMIs to whether they approve or deny certain medications, and a lot of these, expensive anti-obesity medications. Um, but if you look at the history of the usage of BMI, even the person that kind of was the grandfather of the system that later translated into BMI, Ansel Keys from Minnesota, even back then, I think this was back in 1950s or 1960s, even back then he said we should not use, any kind of weight to height ratio to assess individual risk. We should only use it to study population because it really doesn't capture the entire complexity of the disease. But here we are, 50, 60 years later, still using BMI. But hopefully, with these new consensus guidelines, we'll be moving away from using BMI for diagnosis or staging. So, with this new recommendations, waist circumference and especially waist to height ratio becomes very, very important. Basically, especially a waist to height ratio of equal or greater to 0.5. So basically, we want our waist circumference to be less than half of our height, because anything higher than that at that point already signifies an increased metabolic risk. Um, the other things that what they recommend is to measure waist circumference in all adults with a BMI of at least a 25. Um, and they say they don't routinely recommend checking waist circumference if someone's BMI is above 35, which under the old system that kind of puts us in the class 2 obesity, because at that point, the BMI itself already implies a higher risk situation. Um, and they do want to call out and bring their attention to the ethnic and regional cutoffs that we have for not just BMI, but also waist circumference as well, because depending on your ethnicity or your background, your cutoffs for BMI and waist circumference are going to be very different. For instance, a lot of the health guidelines in East Asia, they use slightly different BMI cutoffs. For instance, BMI of 23 is when they start classifying someone as having overweight, whereas here it's BMI 25. And in East Asia and a lot of the kind of regions around it, um, they use BMI of 27 as classifying someone as having obesity, as opposed to a BMI of 30 here in the US, or kind of, which studies more of a kind of a North European population. And there's also different guidelines for what's considered, quote unquote, normal for waist circumference. Um, and with this new algorithm and consensus, it who does it affect the most? Well, it affects the population that's been previously classified as having overweight. So that would be a BMI of 25 to 30. But if someone is within that BMI range, and if they have an increased waist circumference, or if they have an obesity-related complication, at that point, based on the new guidelines, that is enough to start, to diagnose that patient with having obesity. And it affects a lot of the folks that have normal BMI, so BMI of less than 25, but if they already have an obesity-related complication, or if they have increased waist circumference, that's also enough to have to call them have the patient be diagnosed with having obesity. And there are a lot of obesity-related complications. Some of those we always think about, but there's some that I always have to kind of refer back to this list because just in the back of my mind, it just doesn't. It still takes me a while to kind of consider some of these as an obesity-related complication. For instance, we always think about, insulin resistance, right? So within the realm of prediabetes, type 2 diabetes, and the other conditions that fall under the blanket would be something like fatty liver or hyperlipidemia, especially if you have high triglycerides. But the things that I always have to keep reminding myself would be something like atrial fibrillation, um, and asthma, and even, someone having depression or anxiety. All of those are considered to have obesity-related obesity complication. Another one that I always kind of have to remind myself is thromboembolism, right? So if somebody has a DVT or somebody has a PE, unfortunately, obesity predisposes someone to have an increased risk of clots. And another one is cancer. I think the latest number is there are at least 14 cancers that are related to obesity, and obesity increases the risk of those 14 cancers. With the biggest ones being breast cancer. And I think the latest estimates are 1 in 8 women in the US will be diagnosed with breast cancer, um, and also colon cancer. And colon cancer, my goodness, has been exploding in the US and worldwide. And at this point, I think colon cancer is the number one cause of cancer death in the US for young adults under 50. Um, and Another one I really always kind of have to remind myself is inflammatory skin diseases. Um, and then um, or heart failure with preserved ejection fraction. So quite a few comorbidities that are associated with the disease of obesity. So, and this is where the new ACE guidelines want to push you to start considering those as to for somebody to have the diagnosis of obesity, regardless of what their BMI shows. So there's two components to the approach. First, you need the anthropometric component, where basically you measure some component of a patient's body metrics. So whether it be their weight or their waist circumference or their waist to height ratio. So you may diagnose obesity if somebody has a BMI of at least 30, um, but they need another anthropometric measure like a waist circumference or waist to hip ratio, or a BMI of greater than 40, which under the old system would already put you in the class of class 3 obesity or severe obesity, um, being the old definition. Or you could just have two elevated anthropometric measures, even if your BMI is less than 30. You may already be diagnosed with having obesity. Or you could have an absolutely normal BMI and not have any of those anthropometric measures. But if you have direct evidence of excess body fat by using a DEXA scan or by using like a bioelectrical impedance scans, where you can nowadays you can buy a lot of those scales for home use, or at the gyms they have a lot of those in-body or Sika scans, where you hold the handles and they'll kind of try to estimate your body fat percentage. So if you have direct evidence of excess body fat for your age group, that's enough to diagnose somebody with having obesity, because at the end of the day, it's this excess of adipose tissue, it's the adiposity that causes not just the weight-related issues, but also all the negative downstream metabolic complication that are associated with obesity. And then, you want to pair that up with a clinical component as well. So this is when you look at the obesity-related complications. On the metabolic side, you have the insulin resistance, you have the cholesterol, you have the gastroesophageal reflux or fatty liver. And on the mechanical side, you may have things like sleep apnea or osteoarthritis. Um, and then you also have the psychological component that is also an obesity-related complication. And going back, depression, anxiety, and even something that you see quite a bit in the patient population who suffers from obesity is this internalized weight bias, which really translates to a lot of folks, just not even wanting to receive medical care or going to the doctors because this internalized weight bias is, pretty used to be pretty high in medical clinics or in provider settings, which is definitely the last place where the patients want to see that, where a lot of it really becomes of their weight, and then so the psychological and the psychosocial component of that is very, very important. Um, Now, the good news is there's a lot of obesity comorbidities or complications, but it really doesn't take a whole lot of weight loss to start seeing amazing changes in a lot of these conditions. So, regardless of what your starting weight is, you could have a BMI of 40, you could have a BMI of 45, but just losing 5% of your initial body weight, you'll already start seeing changes in a lot of these conditions. So at 5%, you already start seeing changes in your fatty liver and your cholesterol and your heartburn and osteoarthritis. And then once you start getting into the 10% range or the 15% range, which is quite feasible at this point with these new GLP-1 medications, well, at that point, you start seeing not just improvements, but complete reversals of a lot of these conditions as well. At 15%, you start having a reversal of advanced fatty liver. You're starting to put diabetes into remission. A lot of the metabolic issues that are associated with PCOS or hypertension already start to go away as well. So bottom line is there's a lot of comorbidities. The numbers for prevalence are still pretty high, but with the current treatment modalities, you can put a lot of those things into basically remission without, significant weight loss. You don't need to bring a patient to a quote unquote normal BMI to see a lot of these responses. So just 10, 15% of initial body weight loss will already get you there. Which is something I always talk to my patients because, the expectation is, oh my gosh, I used to be, 170 pounds when I was in high school, and then, now I weigh, 350 pounds. You don't need to get back to your high school weight to get there. You'll get there much, much sooner, and then you'll extend your lifespan and health span just with 10, 15% of initial body weight loss. I want to spend the rest of the time talking about GLP-1 medication just because that's been the craze. These are the most effective um, pharmacotherapy modalities that we have for not just diabetes, but for obesities. And the numbers are pretty staggering. If you look at the latest reports, I'm just quoting the RAND report from, I think they published this a few months ago. At this point, the survey data says 1 in 8 US adults said they've used a GLP-1 drug for weight loss or health reasons. And I would suspect the number is actually a lot higher than that because now with so many people using compounded versions of these medications, that's produced at 503A, 503B pharmacies, especially with the recent shortages of these medications, I bet you the numbers are probably double or triple that. So if I had to guesstimate, I would say maybe 1 out of every 7 or maybe 1 out of every 6 people at this point have at some point taken a GLP-1 drug. And among adults with diabetes, a quarter of them report current GLP-1 injection use. Now, let's with the use of these medications getting so prevalent, we do have to, have some kind of guidelines on how to manage these medications. And one big one where there's been a lot of um, different approaches depending on who you talk to is what do you do with these medications in the perioperative period. Um, so historically, every surgeon, every anesthesiologist had their own little approach as far as what they do with these medications. The American Society of Anesthesiologists finally put out a kind of consensus statement. So with these medications, if your patient is on a daily GLP-1 medication, so that would be your older GLP-1 medications, things like Victoza, or Saxenda, where they take daily injections, or it could be oral semaglutide, which is Rybelsus for diabetes. They recommend to hold it just on the day of surgery. Um, but if somebody's on a weekly GLP-1 medication, so this would be your Ozempic or Wegovy, or Mounjaro or Zepbound or Trulicity. Well, at that point, you want to hold it at least 7 days prior to that elective procedure. But the emphasis there is the risk assessment should be very personalized to that patient. Because if somebody's on this medication for, let's say, weight loss, um, and they don't have a whole lot of other comorbidities, well, it should not cause a huge disruption to stop this medication for 7 days or 14 days. But if somebody is taking them for diabetes or advanced diabetes and they're also on insulin, well, disruption there could be very problematic for the patient. So once again, I think it should come down to kind of individualized risk assessment patient to patient. Um, Another area where we see this is with minor procedures, so things like colonoscopies or EGDs. And thankfully, the American Gastroenterological Association also put out a statement guiding us. So what they recommend is generally in patients who do take these GLP-1 medications, they just recommend following the standard perioperative procedures. So typically, no solid food for 8 hours prior to the procedure, and no liquids 2 hours prior to the scope. With the caveat being, if you got to make sure the patient doesn't have any symptoms of nausea or vomiting or dyspepsia or abdominal distension, which at that point they recommend delaying the procedure just to make sure. Now, for those folks who practice in a hospital or acute setting, let's say a patient comes in and needs an emergent surgery or emergent procedure, what do you do then? Well, in that case, what they recommend is still proceeding with the procedure, even though they're not NPO, while proceeding with the procedure by treating the patient as having a full stomach, what they call it full stomach precautions. Even if they had, let's say, if they had been NPO for, since midnight or for 12 hours, because the medication lingers in your system for days to weeks, even if they had done that, the recommendation for the anesthesiologist is to still consider those patients as having full stomach. So at that point, they would consider rapid sequence intubation, or they may do a gastric ultrasound just to see of how much food or how much gastric contents are there, and that will determine how to proceed with anesthesia. Once again, at this point, that's kind of out of our internist hands, and that's more on anesthesia. But still something to definitely counsel patients on, because hey, if you're on this medication, definitely let the surgeon know that you're on this medication and your anesthesiologist know this medication, because the timing and the NPO precautions are going to maybe very, very, very different. Um, and then I want to go over the latest numbers or the latest updates that we have on safety of these medications. Um, and just because at this point, people have been taking these medications for about 20 years, we are collecting quite a bit of data of adverse events with these medications. So one of them, the big one, is pancreatitis. Um, I think historically, when these medications got rolled out, I think we used to think that was a bigger issue than it probably is now. Yes, people do get pancreatitis, but if you look at the recent large randomized control trials and recent cohort studies, they're actually very reassuring, and they point to, people that take these medications show no significant increase in developing acute pancreatitis. So the most recent studies, there's a couple that were published in the American Journal of Gastroenterology. There's one that looked at patients with diabetes from 2010 to 2020. And there's another one that looked at patients from 2015 to 2023. And in those large cohorts, they found no significant increase in pancreatitis. And there's a really big study that was published just this past August, a couple of months ago, in the Journal of American College of Cardiology. And what they found is they looked at systematic review meta-analysis of 99,000 patients, and they still have not found an increased risk of pancreatitis with these medications. Um, so I think practitioners, myself included, are getting a little bit more comfortable in prescribing these medications in somebody who's had pancreatitis before, or somebody who, let's say, develops pancreatitis while on these medications. Although I'm still very, very cautious until more data pops out because there is a real risk pancreatitis. Um, Nobody wants to get pancreatitis, and some cases can be severe enough where you can end up in the hospital. Um, so, and unfortunately, with all of this, a lot of the conditions for which you may take this medication also predispose you to having pancreatitis. So, if you have obesity, if you have insulin resistance, if you have high triglycerides, all of those things will predispose you to having pancreatitis. And if you ever had pancreatitis before, that alone will put you at an increased risk of having another bout of pancreatitis. So I'm still pretty cautious. It's not a blanket recommendation at this point that if you ever have pancreatitis, you should not take this medication. But I think there needs to be a lot of shared decision making at this point, really going over the risks with the patient. If you are going to initiate this medication, GLP-1 medication, in somebody who's had pancreatitis. And another thing to watch out for is these medications. A lot of people will just get mild elevations of lipase um, with these medications without having pancreatitis. Um, so I've seen patients, they just had their lipase checked and they just happen to be in the 300s, 400s, 600 range, but with no other signs of pancreatitis. So that is to be expected. We see that quite a bit in folks who do take GLP-1 medications. But of course, in these situations, we also want to, look at the full criteria for pancreatitis, so lipase, greater than the 3 times the upper level of normal. We want to see some kind of imaging evidence of inflammation or pancreatitis. And then we're looking for the typical pain or the typical presentation for pancreatitis, that sharp stabbing pain that radiates to the back in the epigastrium. Now, another one is we always talk about is gastroparesis. Uh, Now, with gastroparesis, we actually do have higher rates of gastroparesis with this medication. That is true. The absolute risk is small, but definitely noticeable at 2 to 4%. But the good news is most cases are very mild and they reverse upon discontinuation. Um, with gastroparesis, we mostly see this in folks, who take Ozempic or Mounjaro for diabetes, and that patient population is already predisposed to having unfortunately developing gastroparesis. Um, but but every time you hear about these medications on social media, or every time you hear about these medications, in the newspaper headlines, they always talk about stomach paralysis. So definitely worthwhile to talk about these things with a patient as well, and knowing what to expect and the possible risk. The good news is, it's super rare for somebody to develop gastroparesis because of these medications that doesn't go away upon discontinuation of the drug. And, even if you don't take these medications, what the natural GLP-1 hormone does is it delays your gastric emptying. So this is a natural function of the drug. So what I tell my patients is, this is actually a feature of the drug and not a bug. Um, and it's, for most people, it's not a permanent thing. Um, Biliary disease, unfortunately, there is increased risk with for developing gallstones and developing acute cholecystitis with this medication. The absolute risk increase is about 27 per 10,000 per year. Um, most people suspect it's not the medications per se, but it's the rapid weight loss that causes somebody to develop acute, gallstones or acute cholecystitis, because we see this as well in people who lose weight without medications or people who had bariatric surgery. Um, and especially kind of the more advanced bariatric surgery where people lose quite a bit of weight over a very short period of time. Um, Finally, ophthalmic events, that's been on the news lately. We've always known about the diabetic retinopathy, so it's okay to start these GLP-1 medications in folks who have pre-existing diabetic retinopathy. We just make sure they don't. We just make sure we go slow, and people who have poorly controlled diabetes don't correct their hyperglycemia too fast, because this is when we see worsening of the diabetic retinopathy. Most of it is seen in the semaglutide use population, um, and it's a little less pronounced with tirzepatide, which is Mounjaro, but definitely something to watch out for. And then there's this has been floating around the news probably since last fall, last winter. This I'm sure you've seen the headlines where, oh my gosh, Ozempic, can make you go blind. What they're referring to is this condition called NAION, or non-arteritic anterior ischemic optic neuropathy. What they're referring to is there were studies based on, I believe, the VA data, where they found a possible association between semaglutide use and NAION. Um, and this is association based on observational data. I think the most recent update was published in the American Journal of Ophthalmology back in June. But reassuringly, most recent meta-analyses and randomized control trials have really not confirmed this link. And even with um, if you look at the studies and if you look at observational data, the absolute risk is very, very low, less than 0.1%. And then medullary thyroid cancer, we always talk about it. It is a black box warning, but it's only based on rodent data and we really, the increased risk of medullary thyroid cancer hasn't really been borne out in large scale human studies. But we still ask people, whether they have history of medullary thyroid cancer or MAN2. So that one, definitely not as worried about. And then there was a small signal that, people that kept popping up last year about possible suicidal ideation. This is based on pharmacovigilance analyses from the FDA and WHO databases. But the good news, the meta-analyses and RCTs and cohort studies found no statistically significant difference in rates for suicidal ideation or worsening depression in patients who use these medications. Now, there are some new indications that have popped up for these medications, not just diabetes and obesity for the past couple of years. For Wegovy, which is semaglutide, it's the weight loss version of Ozempic. Now the FDA approved it for three main indications. So weight loss, which we knew about, which a few years ago they actually lowered the age to pediatric population. So you can start Wegovy in somebody as young as 12 years old. And a couple of years ago, they added the indication for reducing of MACE, or major adverse cardiovascular events. And this is based on the SELECT trial data, where they found an amazing 20% reduction in MACE, which included cardiovascular death, non-fatal MI, and non-fatal stroke. And just recently, just a few months ago, there was an accelerated approval by the FDA for use of Wegovy in MASH, which is formerly known as NASH, for folks who have moderate to advanced liver fibrosis. And for Zepbound, it's improved for chronic weight management. And last year it was approved for obstructive sleep apnea. Even though it was approved for obstructive sleep apnea, a lot of insurance companies still don't cover this medication for OSA, but hopefully that will change in the near future. And finally, just general pearls when you talk to patients, because I'm sure, especially in the primary care setting, everybody keeps talking about it. Everybody's on this medication, even if they don't talk to their PCPs about it. Um, and the use is only increasing. So the clinical pearls are definitely start slow and titrate slow. And if patients don't do well on the medication, there's no real pressure to increase the dose as you go along. What I tell the patient is ideally we stay in the lowest dose for as long as possible, and we only need to go up once you feel like the medication is not doing anything for you. Um, it's very important to discuss potential side effects, including GI symptoms ahead of time. So nausea, diarrhea, and then reinforce, things that'll help you avoid those side effects. So hydration, eating smaller but more frequent meals, um, lower intake of saturated fat because that really makes people's nausea worse. And then discuss, perioperative um, uh, precautions, let's say, hey, make sure to tell your surgeon you're on this medication. Um, and then talk to patients about um, potential interruptions or restarting strategies, because once you're off this medication for 2, 3 weeks, you definitely need to start lowering the dose before you kind of get back into it because it may make you sick. And finally, reproductive counseling. So far, um, this medication, we still want to avoid in pregnancy, and there's a recommendation to be on some kind of birth control for women who are on this medication, um, and especially for women or people that take oral birth control pills, because those oral birth control pills just people suspect just don't absorb all that well while you're on this medication, so they become markedly less effective. So if your patient is relying on OCPs for birth control method, they really do need a backup method once they initiate that medication or titrate the doses. All right, and I think this should be it. I'm only 1 minute over.
Thank you so much, Dr. Kim. That was fantastic. Great reminders on weight management issues and GLP-1s. I do have a few questions for you
Yeah.
from the group. The first one, NIH waist is 1 centimeter above the iliac crest. Is that the same way to measure for waist to height greater than or equal to 0.5?
Oh, that's a great question, and there's a lot of debate about that. I think most of the studies use either the height right at at the top of the iliac crest, with the tape measure being horizontal and parallel to the floor. Some people use 1 inch above. The new guidelines actually want you to take the middle spot between your lowest rib and your iliac crest, because they say it's actually more accurate in women and it's more accurate to capture the full measure of your adiposity, not adiposity but your visceral fat that may be present. So I think the newer guidelines actually recommend kind of that midpoint between your lowest rib and the iliac crest as having a higher sensitivity for risk. But most studies still use kind of right at the top of the iliac crest for measuring waist circumference.
Great. One provider wrote that many of my patients get body DEXA scans from maybe Body Spec as one provider. What is your take or recommendation on using these scans?
Yeah, DEXA scan is, many people consider it as the gold standard of checking body composition. Highly, highly recommended for, most of my patients. Body Spec is a great company in the area. I think they only service, 7 or 8 major cities. I'm glad we have this in the Seattle metro area. Um, it's definitely more accurate than your electrical bioimpedance tests, the ones you see at the gyms or the weight loss clinics where you kind of hold the handles. Um, so I think the only thing that's more accurate than DEXA scan would be an MRI, but obviously nobody's going to get an MRI for this level. So yeah, if they can get a DEXA scan, I think with Body Spec you can get it for what, 55, $60. That's the cheapest I've seen in the industry. highly, highly recommend seeing my patients, especially those patients who, you know, the patient population who may be under muscled, right? So we're talking about folks past the age of 60, especially for females, after menopause, to where your BMI may be normal, um, but you really have a lot of adiposity. You really have a higher fat percentage that's just under-recognized. So yeah, so huge fan of DEXA scans, and hopefully they continue getting cheaper and cheaper.
Great. You mentioned no real connection in people between GLP-1s and thyroid cancer, but what about the two thyroid cancers in the 250 people on the 5 milligram tirzepatide group in the 3-year obesity safety study?
I haven't looked at that data closer. I know that the I think the reassuring data is with the medullary thyroid cancer. There is some data, I think, in the Diabetes Journal from 3 years ago that noticed a possible small increase in the rates of overall thyroid cancer, which includes, papillary thyroid cancer. Um, but so far I haven't seen any recent updates as far as how that translates as far as, you know, to kind of real world numbers. But I think the reassuring data is with medullary thyroid cancer, but there may be a signal with increased risk of overall thyroid cancer that doesn't include medullary thyroid. Um, but um, but yeah, I'll be curious to see once we get more and more numbers if that signal would, gets a little stronger with more people.
Great. And then last question, can you comment on using compounded GLP-1s? This question comes up all the time.
Absolutely. So we there's a lot of controversy with compounded GLP-1 medications. All the major societies, so like the Obesity Society, the Obesity Medicine Association, they don't recommend, use of compounded medication due to the variability of compounding pharmacies due to safety reasons. Um, I think, regardless of that, compounding is there. It's been there. It's filled in a major gap for a lot of patients whose insurance, most insurance companies don't cover these medications. Um, so there's a lot of debate now whether they're still legal. I know a lot of compounding pharmacies are using the loophole of well, I don't know if I want to call it a loophole, but they were there when there was a shortage of a lot of these medications 2 or 3 years ago. Now they're still here. I don't think they're going away anytime soon. I think most of our patients are continue using these medications. Um, so what I would tell my patients is that because they're going to use it regardless of what you would tell them, what I would tell my patients is if you are going to use a compounded version of the medication, I will make sure you get it from a reputable 503A or 503B pharmacy. Um, and I would, definitely vet the pharmacy. Um, and make sure that pharmacy is under the FDA regulation and supervision, and definitely pay attention to the dosing because a lot of pharmacies they use different formulations depending on the prescription label. The dosing may be very confusing. So the biggest thing that I see, the biggest issue is people giving themselves the wrong dose of the medication because they're just very little supervision and it's not very standardized. And a lot of pharmacies um, make it very difficult to know what dose you're supposed to take. So if you were to take it, I would recommend close communication with your medical professional, especially for the dosing, and then make sure whatever pharmacy you are using, make sure it's a very reputable pharmacy that doesn't use research grade materials because there's a lot of compounding pharmacies, unfortunately, and this is not legal, but unfortunately, they're using research grade active ingredients that should not be, that is not allowed for human use in the US.
Great. Well, thank you so much, Dr. Kim. I will have you check the Q&A when after you are done here to see if any other questions have come through that you can answer for us. Thank you.
Thank you.